So I apologize for not introducing myself to the wider group. Mia Biondi, I'm trained as a primary care nurse practitioner, and I have a special focus on liver disease, and it's definitely a passion of mine. Have practiced in a few different environments and different types of practice in primary care. And so I wanted to connect three sort of themes that I've heard. So from that initial talk by Maru, I was wondering if you could speak a little bit more about the stigma aspect and how adapting to advancements, and sort of elaborate a little bit on that.
So, meaning how patients might perceive stigma or how you might detect stigma? I guess I don't really understand your question.
What that actually means, adapt to advancements. So that could be advancements in types of disease. How does that tie into like reducing stigma in conversations and using language?
I see. Specifically with respect to stigma, I guess, there are genetic modifiers. That's just an example. Those are not specific subsets of patients, just to be clear about that. But there are genetic modifiers that may predispose a patient to have very aggressive disease, say, without having significant obesity, right? But a lot of the stigma is associated with obesity and just this concept that the patient did it to themselves. This is like a very important issue to some people, and it makes them ashamed, which is unfortunate because then they avoid care. So I think that the ability to parse out new groups of patients, I think, will allow those patients to have even less stigmatization. But I really think that just starting with not using stigmatizing language is very helpful just for the overall group. And it really, I think, enables a conversation of the root causes of the disease. I really start with, you have dysfunctional metabolism. Look, you've got diabetes, you got hypertension, et cetera. And I tie it all together to why the liver is involved in that, and then use that as a platform to help them understand how you treat it and how to make it better. So that's sort of a roundabout answer, but
that makes a lot of sense. I think that's really helpful for us to sort of see the future, envision what might be coming next and how we incorporate this language. And Manal, I'll just sort of lead in from that because you spoke about exercise quite a bit. And I don't know about other folks on this setting, but my patients are so tired of hearing me ask them about exercise. And I think what I like about our Canadian obesity guidelines is we're inviting patients to discuss obesity. So saying something along the lines of, would you like to discuss your BMI today? Would you like to discuss lifestyle today? And you made a really important point, I think, about things like SMART goals, and maybe that there's not tremendous evidence around setting SMART goals. And maybe it's a good use of our time, and maybe it's not a good use of our time. So I guess we're all kind of looking for guidance on how to talk about exercise with patients and clients.
I think one thing something I've learned along the years is we can't be dictative in what we ask our patients to do. We have to have them come to the table and say, what do you enjoy? What can you do? What are your limitations by which you can do it? And partner with them in a manner. So for those patients that can't bear weight, maybe non-weight bearing exercise is better. Those patients that, enjoy bicycling or whatever it is, or maybe for those that have such physical limitations that we need to really partner them with a trainer that can be tailored in an approach to increasing activity. This requires a team approach with a patient, and really their collective buy-in into what they can do, what goals they're willing to set, what goals they aren't willing to set, and how we can frame a menu of options that could work for them.
Thank you. Thanks so much for that answer. And maybe I'll just end with Dr. Harrison. So I'm going to really simplify your talk, and I'm sorry, that's how us in primary care think. And I've said to people, is treating obesity treating liver disease that's related to fat in the liver? And people say no. The hepatologists definitely say no, that's not true. This is not a NASH drug, right? Some of what you mentioned. But I think, I'd be curious on your perspective to know if the goal is weight loss and these medications lead to weight loss, are we actually treating liver disease by treating obesity? And can we frame it to patients?
I mean, absolutely you are. I use GLP-1s in my practice. In fact, I probably prescribe more GLP-1s than I do rifaximin for hepatic encephalopathy. I mean, it's just something that has become a mainstay of treatment. I mean, we've advocated weight loss for the better part of, well, ever since I've been in training at the turn of the century. I mean, back when Maru and Manal and I all trained together. So, I mean, we've been advocating this for a long time, and now we finally have therapies that could augment weight loss. So yes, this has a positive impact on liver disease, on the steatosis, on the inflammation. And I think ultimately there will be a benefit on fibrosis. I liken this to bariatric surgery and an injection. It just takes longer to get the fibrosis benefit, but it's going to come. If you think about scar tissue in the liver, this is from a very simplistic patient perspective, but any liver disease that you have, whether it's alcohol, fibrosis from viral hepatitis, from autoimmune hepatitis, cholestatic liver injury, drug-induced injury, it all leads to the same thing: activation of stellate cells and laying down of collagen. So if you take away the insult for injury, you cure the C, suppress the B, treat the autoimmune, quit drinking alcohol, or in this particular case, you improve the fat by improving metabolism, you will eventually have a positive impact. I just think it takes longer. In patients with more advanced disease, I worry about the GLP-1 use, as I mentioned, because we don't know what the effects are going to be in patients who have sarcopenia. That's my main concern with it.
Thank you. I wish we could keep going. I really do, because I have so many questions for all of you, but I think I'm going to have to pass it along to Mike. Thank you so much to our fantastic speakers. I think that was a really lovely session.